What do you know about blood transfusion? What do you know about blood groups and blood types? What's it mean to be A positive or AB negative? What do you know about type-in screening and how and when to do a type-in cross? These are the topics we're going to nail today at Citizen Surgeon. All right, welcome back to Citizen Surgeon. I'm so pumped that you're joining us today for this talk on blood transfusion, blood groups, and types. This is a topic that is so important to surgeons and anybody who has the responsibility to order and transfuse a patient. Blood is a scarce resource, and we need to know when, why, and how to order and use it. And that's why this discussion is so important. I already know that today is going to be an awesome topic, so go ahead, share it with your friends, your colleagues. I think they're going to find a lot of value here. If you haven't had a chance, go ahead, subscribe, turn on those notifications so you can be aware of when these videos are coming out. I'm going to try to put these out about once a week, so you're going to have a really nice collection of surgical content to refer to, whether you're studying for exams or, of course, just training and getting on the wards and in the ICU and the OR. If you haven't had a chance to check out citizensurgeon.com, check that out. A ton of free resources there, whether that's to help you study or reference guides. Also in the blog, I talk about all sorts of topics, whether it's burnout or how to find that first job, topics that are important in and out of the operating room. Also, sign up. I got a new newsletter coming out called the Saturday 6. This is just going to be 6 topics that I think are important from the week. This could be a podcast that I'm listening to. It could be that a book that I'm reading that might not have nothing to do with surgery. It could be a leadership book. Also, it could be, we'll talk about maybe the most important clinical article of that week. Go to citizensurgeon.com. You can sign up for the newsletter there, the Saturday 6. All right, let's get on to blood transfusion, groups, types, type and cross, type and screen. So as always, I like to talk about why. Why do you need to know blood transfusion, blood groupings? I firmly believe that if you're a surgeon, every operation you're going to go into, you're going to have to make an assessment of whether or not you may need to give blood. And it's your responsibility to make that decision knowing that blood is a scarce resource. We can't just use O negative blood, which as we'll find out is the universal donor, for all of our cases, because it is in short supply and it is extremely valuable. The other reason is because we need to know if we give the wrong blood, what happens? You can have acute and delayed transfusion reactions, and as we see here, they can range from something simple like fever or mild hemolysis to things that are more severe, like TRALI or transfusion-related acute lung injury, or TACO, or death. So blood transfusion, super important topic, both from the responsibility of giving blood as well as what happens if you give the wrong blood, and we're going to learn about all of this today. For all of these talks, I like to have particular goals. So the goals for today is number 1, understand the ABO blood group system. This is the most important blood group system to know. Second is let's understand the RH blood group system. And we're going to talk about hemolytic disease of the newborn as well as RH sensitization and why that's so important. Third and fourth, we'll talk about when, why, and how to do a type and screen, and when, why, and how to do a type and cross. All right. Let's go. So first, I think it's important to get an idea of how common blood utilization is. And know that every year in the United States, we use 21 million blood products. Now that's an astounding number. Every day, we use about 36,000 packed red blood cell units, as well as 7,000 and 10,000 of plasma and platelets. So this is a shout out to the American Red Cross. This is a shout out to you to go donate blood today and donate as often as you can. And also know your blood type. So if you're something really rare, like AB negative, you need to be donating blood because you represent a really small percentage of our population and your blood's in need. Of those 21 million units of blood products, how is it distributed? So you can see that as surgeons, we're responsible for about 55% of blood utilization, and that's in elective surgery. Trauma accounts for about 15% of blood utilization. So surgeons, in one way or another, we are responsible for about 70% of blood utilization in the United States. 20% of that is for elective cardiac surgery. So for those of you going into cardiac surgery, you need to know this blood stuff even more. It's even more important. A great resource that I used for this talk today, one of the resources, is the clinical use of blood. Now, this is a handbook that's put out by the WHO. It's freely available. I'll put the link to it in the discussion in the comments so you can read it. And I would go through this because it's going to go through all of the different blood products. It's going to go through the principles of blood transfusion. It's going to go through type and cross, type and screen, when, why, and how. It's going to answer these questions so that you can nail it and be very confident so that when you're going into an elective operation and you need to decide, gosh, do I need to do a type and screen or type and cross this patient? You're going to have that knowledge. So there are a ton of different blood products. Usually we're just working with packed red blood cells, fresh frozen plasma, platelets. I use platelets very often as a pediatric surgeon, but also there are other blood products. You have leukocyte depleted RBCs. You have cryoprecipitate. So it's important to know all the blood products that are available, when and how to use them. Now, we're not going to get into specific blood products in this talk. We're going to save that for the next talk when we're going to answer why, when, and how to give FFP or cryoprecipitate and what are the clinical indications for those. But today we're going to do an overview of blood transfusion, get comfortable with our blood groups, blood types, as well as type and screen, type and cross. So first is the ABO blood group. Now, this is the most important blood group system to be aware of, and you really have to know this and why it's important. So the first thing to know is that the ABO blood groups are inherited. They are inherited on a single gene on chromosome number 9, and this gene has 3 alleles. It's encoded with 3 alleles, and these alleles are designated with an I. That I stands for isoglutinogen, and they code for a glycosyltransferase. Now, the 3 alleles are IA, IB, and little I. Now, this inheritance is not simple Mendelian inheritance because you have these 3 different alleles. It should be known, or you should know, that A and B are co-dominant. So if you inherit just the IA allele, you're going to have type A blood. If you inherit the IB allele, you'll have type B blood. If you inherit both type A and type B alleles, you'll have type AB blood. And if you inherit neither of those and just the little I, which is without a dominant antigen, A or B, then you'll have type O blood. And let's go through a little diagram that makes this a little bit more clear. So in this diagram, this is going to show you the different blood groups as well as the associated antigens and antibodies. So first, let's take blood group A. Now that represents about 40% of the US population. So if you have blood group A, that means that you express the A antigen and you have antibodies to the B antigen. So blood group A has antibodies to the B antigen, but does not have antibodies to the A antigen. Now, one important note is that those antibodies are IgM antibodies. Now, review in your immunology what it means to be IgG and IgM. But the important thing in this discussion is that IgM antibodies, which is the ABO blood group antibodies, do not cross the placenta. So you can have a blood group in a mom who's type A and a fetus with a type B blood group, but because those IgM antibodies don't cross the placenta, you're not going to have hemolytic disease of the newborn. Those antibodies will not attack that fetus. All right, so let's look at blood group B. Blood group B means that you have the B antigen, you have antibodies to the A antigen. If you're blood group AB, that means you express both antigens on your blood cells, but you don't have neither of the antibodies. And if you're blood group O, you have no antigens, but you have both antibodies. And if we think about the development of our immune system, the development of antibodies, the reason that we have antibodies to B, if we're blood group A, and we don't have antibodies to A, is that those antibodies go through positive and negative selection as we're developing. So as the immune system is developing, we get rid of the antibodies to antigens expressed by self. So if we express the A antigen, we want to get rid of the anti-A antibodies so we don't attack ourselves. You probably have to go review some immunology, but get comfortable with the idea that The A antigen is in blood group A, and those people have antibodies to B. In this schematic, I think it's worth it to talk about the inheritance of the ABO blood groups. And this does get a little complicated because you have 3 alleles. So we can see that here, if we have a blood group O person who has a child with another blood group O person, their child is going to have blood group O because there's no possibility of inheriting those antigens to express A or B. And we know that because if you're blood group O, that means you're not having any of the A or B antigens because they would be dominant. Now, as we expand the blood groups of a different possible parent, we can see that the ranges become quite complicated. So it becomes possible, if you look at this chart, that a blood group A parent could have a child with a blood group B parent, and that child could be blood group O. But just look over this table and you can see that as you have different blood groups between parents, you can have quite a variety of blood groups in that fetus. All right, I hope that's clear. We're going to have a quiz at the end that I'll give you access to through citizensurgeon.com, and you can link to it and you'll be able to test yourself to see if you really did nail the ABO blood groups and the other topics today. So now let's go on to the RH blood group. Now the RH blood group is the second most important blood group. This is also inherited. It's inherited by a gene on the first chromosome, and that codes for RhD protein. Okay. Now the Rh stands for rhesus. It was first studied and evaluated in rhesus monkeys, and so the Rh is carried over from those initial studies. And this is quite simple Mendelian inheritance, and we'll go through that with a couple of Punnett squares. One thing that's different about Rh and the ABO blood groups is that Rh negative individuals don't have antibodies to Rh protein, but they can become immunized if indeed they're either exposed to Rh positive blood through an incorrect blood transfusion, or if, for say, they are a Rh negative mother who has an Rh positive fetus and there is hemorrhage of those D positive cells into the mom, that would create this Rh sensitization. Looking at a couple of Punnett squares, we can see that if we have 2 Rh positive parents that have heterozygosity for the RhD protein, we can see that 75% of the time that child will be Rh positive, but 25% of the time they'll be Rh negative. If we take another scenario where you have an Rh negative mom, which is important, and a heterozygous dad, we can see that 50% of the time that baby is going to be Rh positive, and 50% of the time they're going to be Rh negative. And this is where the Rh blood group system becomes really important, because we're going to talk about hemolytic disease in the newborn. Now, hemolytic disease in the newborn is where antibodies from mom attack the blood cells in the fetus. And this will happen because of sensitization in an Rh negative mom so that she develops Rh positive antibodies. This is important because hemolytic disease in the newborn has a spectrum which can be mild, maybe mild jaundice in the baby from hemolysis, to very severe anasarca in the fetus, hepatosplenomegaly, and even death. So it's important to know this really, really well. So how does this happen? This happens when you have Rh negative mom, Rh positive fetus. We talked about the inheritance. If you have an Rh negative mom and you have hemorrhage of D positive cells into mom, now this could happen during an amniocentesis or a chorionic villus sampling or a cord blood sampling. It could happen by a 3rd trimester miscarriage or trauma during birth. If that happens, you get sensitization in the mom. Now, that's not important in the first pregnancy. In the first pregnancy, unless mom was previously sensitized, she doesn't have those antibodies that are going to pass to the fetus. And this is an important other point. And that's that the antibodies to RhD protein are IgG. So the IgG antibodies cross the placenta to attack the fetus. So we can see through this diagram that after you get sensitization in mom, in the second pregnancy, those IgG RHD antibodies cross the placenta, attack the fetal RBCs, and that leads to hemolytic disease in the newborn, which, as we were talking about, can cause everything from mild jaundice to anasarca, hepatosplenomegaly, hemolysis, and death. And this is one of the reasons why the WHO, and as part of modern antenatal care at 28 weeks, moms are given RhoGAM or Rh immunoglobulin so that they don't get sensitized or develop those Rh antibodies. All right, so now we've nailed the ABO blood group system. We're totally confident with the Rh blood group system. We know about hemolytic disease in the newborn and why it's really important to avoid that sensitization in mom. And now let's get on to type and screen and type and cross, knowing when, why, and how. So how do you do a type and screen? You can see this little slide here, group AB. This person definitely knows how to do it. And so how do you do it, and when do you get a type and screen? Type and screen is so that you can determine what the ABO blood group is and what the Rh type is. Also, we screen for antibodies with the indirect Coombs test. And those antibodies can include, or antigens can include, the KEL, the Duffy, the Epsilon, as well as about 30 others to screen to see if there are antibodies within that plasma. And there are two different ways that you can do a type and screen. The first way is called forward type, and that's where we add known antibody to a patient's red blood cells. The reverse type is where we take donor RBCs with known antigen, so we know the type, and we add those to a patient's serum. And then we can determine what the type is in that scenario. Both forward and reverse types are done for a safe type and screen. And so let's check out the forward type. The forward type involves a first stage and a second stage. So in the first stage, the patient RBCs are mixed with known antibody. Here, let's say anti-A, anti-B, anti-Rh. They are washed, and in the second stage, they are mixed with anti-human globulin, also known as Coombs reagent. After they're mixed with Coombs reagent, we look for agglutination. And so let's look at a couple of examples. So here's an example of blood group typing with a patient with type A blood. So we take a sample of that patient's blood and we add in some anti-A antibody. What happens? Well, first we can see that the anti-A antibody will interact with the A antigen expressed on that patient's RBCs. We'll wash that, we'll combine it with Coombs reagent, and that Coombs reagent is a human immunoglobulin, and so that will interact with these anti-A antibodies. And when that happens, you get agglutination or clumping on the slide. Let's see what that looks like. So here on screen left, you can see that there's no agglutination. Where on screen right, there's clumping of all these red blood cells. So it's not subtle, and you would say that if indeed you get this, in our particular example, you would have an interaction between a particular antibody and an antigen, and you could say that that is a positive result with positive agglutination. So let's take that same type A blood and let's add anti-B in it. What happens? So when we add the anti-B antibodies, they just kind of float around. They don't connect with anything because there's no B antigen to be expressed. When we add in the Coombs reagent, we also don't get an interaction, and so in that scenario, we would not see any agglutination. There'd be no clumping of blood. When we look at reverse type, we do basically the opposite. We do both so that we can be safe and accurate. So in reverse type, we're taking washed RBCs with a known antigen, and we're going to mix that with the sample of the patient's serum. And the sample of serum is going to contain those particular antibodies based on what type of blood the patient has. We combine the two, we wash it, we add in the Coombs reagent, and again, we look for agglutination. So if we are using a washed RBCs expressing the A antigen, and the patient's serum has anti-A antibodies, then we would see agglutination in that particular scenario. All right, so let's do a test and see if you guys have it all figured out. So let's take a mystery sample of blood and let's do a forward type and screen, mix in some anti-A antibody, anti-B antibody, and anti-Rh antibody and see what happens. So in this particular scenario, when we do that, we see that after adding the Coombs reagent, we get clumping in anti-A vial, clumping in the anti-RH vial, but no clumping or no agglutination in the anti-B. So what blood group is this patient? This patient is A positive. Let's take another scenario. We have agglutination in the anti-A vial, agglutination in the anti-B vial, but no agglutination in the anti-RH vial. What blood type is this patient? This patient is AB negative, and we'll come to see that this is one of the rarer blood types. Screen is where we screen for different antibodies, and there are about 30 different antibodies, and the Kell, Deftly, Epsilon ones are most important, and if you have significant levels of antibodies, then that can lead to an acute transfusion reaction. And so what happens if we have a positive screen? If we have a positive screen, we can do titrations to see the amount of antibody to that particular antigen, whether it's Kell, Deftly, or one of the other ones, and if that is going to be too dangerous to give to the patient. All right, so now we have total confidence in ABO blood groups. We know the RH blood group system. We know what a type and screen is, and now let's look at a type and cross. All right, so what is a type and cross? And the major question that we have to ask ourselves is the donor blood compatible with that particular recipient? So it's important to know that when you do a type and cross, you're doing more than just analyzing that donor or recipient blood. What you're doing is you're setting aside a particular unit of blood for use. So that blood is no longer available to other patients in your hospital or your region. There are two types of type and cross that you can do. One is serological, and that's where you're actually mixing patient serum with donor RBCs to see if there is compatibility. And the second is called electronic cross-matching, and that you can only use if you have a negative antibody screen, if you've had a positive antibody screen or multiple previous transfusions. You can't do electronic cross-matching, and you'll need to do a serological cross-match or an immediate spin cross-match. So I know that we covered a lot of information there, really important stuff. There's one more thing, and I want you to be able to answer this question. Who can receive what blood from what donor? So let's say you're O positive. What blood can you receive? Let's say you're B negative. What blood can you receive? Let's say you're AB positive. Who can you give blood to? All right, let's check out this table, and it has all of the answers as well as the distribution of the different blood types across the United States. So when we look at this, we can just take a quick look and we can see that across the x-axis is the donor and across the y-axis is the recipient. When we look down the O negative column, we can see that O negative can donate to any recipient, which is why we call that the universal donor. And you can see that the distribution-wise, only 7% of Americans are O negative blood type. So if you're O negative, go and donate. You're the universal donor. We use that blood in cases of trauma or emergency release of blood, and it's a really important blood to use. This should also give you the perspective that we should be responsible when utilizing blood. And if we think we're going to need to give blood, don't rely on O negative blood, which is quite rare, but instead get a type and screen and a type and cross so you can be responsible and give the appropriately typed blood. Let's look at the x-axis and across the AB positive. We can see that they're the universal recipient. They can receive blood from anybody, all right? Now, this only accounts for about 3% of the population, but that's a lucky 3% if indeed they do need to get blood. Going through, you can see that different blood types are able to give and receive to other blood types based on whether you have a green check mark or a red X. Now, plasma is a little bit different. And plasma you can think of as almost the opposite or a little bit the opposite of blood donation and receiving. So what type of plasma can a type A blood group receive? Well, they can receive A or AB plasma. Type B can receive B or AB plasma. Type AB can only receive type AB plasma. And type O can receive any of the different plasmas, and that's because of the circulating antibodies present in that donor plasma. So putting it all together, I think we've had a good discussion today. You should be totally confident in ABO, RH blood groups, type and screen, type and cross, when, why, and how to order these, how to be responsible with blood and to avoid acute transfusion reactions. And if you want to test yourself, I want you to go to citizensurgeon.com. You'll be able to find a link to a test or a quiz on this so you can be totally comfortable that you're going to be able to get these questions right, either in some board exam or an in-service exam, maybe a USMLE or a nursing test you have coming up, or when you're on the wards and in the operating room and you really want to be confident in how to determine or when you're going to need to answer these particular questions. Finally, I hope you found this valuable. Definitely subscribe if you haven't had a chance to subscribe. Share this with your mates and colleagues. My goal is to create a really high value resource for surgical trainees out there, because when I was through training, there wasn't a lot of really good, valuable content. Also, check out citizensurgeon.com. I think you're going to find a lot of good stuff there. And I started a new newsletter called the Saturday 6. It's going to have 6 items of what I'm going through that particular week and what I think would be really valuable to you. That might include a podcast I'm listening to, or a book, surgical and non-surgical, something that I'm going to find that you're going to have a lot of value in. Also, I'll review the best or the most important clinical paper that I've read that week. It could be a review article or something other that you should really have in your knowledge bank. So go to citizensurgeon.com, sign up for the Saturday 6 newsletter. Also, engage with the community. Throw some comments down in the discussion section. If you've already done it, you know that I get right back to you. And make this a really active community so you're increasing the value not only to the program and what videos that I'll produce for you, but to each other and the discussion that you'll have. All right, well, I'll look forward to touch basing with you and meeting you in the comments. And the next video, we're going to be going on transfusion, all of the different blood products, when, why, and how to use them. All right, peace out. Be safe.